I will start with the mitral stenosis. Stages of mitral stenosis are divided to 4 stages, A, B, C, D. As per definition, the patient who's at risk of mitral stenosis with mild valve dooming during diastole, and there is normal transmitral flow velocity with no symptoms or hemodynamic consequences. For stage B, there is progressive mitral stenosis with rheumatic valve anatomy changes, with commissure fusion and diastolic dooming of the mitral valve leaflet, with mitral valve area more than 1.5 centimeter. There will be increasing in the transmitral flow velocity. Mitral valve area, as I mentioned, is 1.5 with diastolic pressure, half time less than 150 milliseconds. There will be no symptoms, but some hemodynamic consequences, mild to moderate LA enlargement, and normal pulmonary pressure at rest. Stage C, it is asymptomatic severe mitral stenosis. We will have rheumatic valve anatomy changes with commissure fusion and diastolic dooming of the mitral valve leaflet. There will be also mitral valve area less than 1.5, or it can be less than 1 centimeter in very severe MS. The hemodynamics will be, as I mentioned, mitral valve area 1.5, diastolic pressure half time more than 150, or in severe MS it would be 220. There will be no symptoms, but there's some hemodynamic consequences, which is severe LA enlargement and elevated pulmonary pressure more than 30. Stage D, it's almost the same stage D. Stage D is almost the same stage C, but the difference is in the symptoms. There will be decreased exercise tolerance and exertional dyspnea. I'll talk about the diagnosis and follow-up recommendation. TE is indicated in patient with sign or symptoms of mitral stenosis to establish the diagnosis. Quantify hemodynamic severity to check the mean pressure gradient, mitral valve area, pulmonary artery pressure, and assess concomitant valvular lesions, and demonstrate valve morphology to determine suitability for mitral commissurectomy. This is a class 1. TE should be performed in patient considered for percutaneous mitral balloon commissurectomy to assess the presence or absence of left atrial thrombus and to further evaluate the severity of mitral regurg. It's also class 1. For the diagnosis and follow-up also, there is exercise testing with Doppler or invasive hemodynamic assessment is recommended to evaluate the response to the mean mitral gradient and pulmonary artery pressure in patient with mitral stenosis when there is a discrepancy between the resting Doppler echo and clinical symptoms or sign. This is class 1. For the medical therapy in patient with mitral stenosis, it's a class 1 to use the anticoagulation, vitamin K antagonist, or heparin. It's indicated in patient with mitral stenosis and AF, either it's paroxysmal, resistant, or permanent, or patient with MS and prior embolic event, or MS and a left atrial thrombus. Heart control medication can be benefit in patient with MS and AF and fast ventricular response, which is class 2A. In patient with heart rate control may be considered for patient for patient with MS in normal sinus rhythm and symptom associated with exercise. This is class 2B. For the intervention recommendation for mitral stenosis, percutaneous mitral balloon commissurectomy is recommended for symptomatic patient with severe mitral stenosis, mitral valve area less than 1.5 centimeter, stage D, which is symptomatic, and a favorable valve morphology in the absence of any contraindication. This is a class 1. Mitral valve surgery is indicated in severely symptomatic patient, NIHA class 3 or 4, with severe mitral stenosis, mitral valve area less than 1.5, stage D, who are not high risk for surgery and who are not candidate for or failed previous percutaneous balloon commissurectomy. This is a class 1 also. Concomitant mitral valve surgery is indicated for patient with severe mitral stenosis, mitral valve area less than 1.5 centimeter, stage C or D, who's going to undergoing other cardiac surgery. This is class 1. For the percutaneous mitral balloon commissurectomy is reasonable for asymptomatic patient with very severe mitral stenosis, mitral valve area less than 1 centimeter, stage C, and favorable valve morphology in the absence of any contraindication. This is class 2A. For mitral valve surgery is reasonable for severely symptomatic patient, NIHA class 3 or 4, with severe MS, valve area less than 1.5 centimeter, stage D, provided there are other operative indications. This is class 2A. Also, the mitral balloon commissurectomy may be considered for asymptomatic patient with severe mitral stenosis, mitral valve area less than 1.5 centimeter, stage C, which as I mentioned, he's asymptomatic, and favorable valve morphology, who have new onset of AF in the absence of any contraindication. This is will be class 2B. For balloon also may be considered for symptomatic patient with mitral valve area more than 1.5 centimeter if there is evidence of hemodynamically significant mitral stenosis during exercise. This is class 2B. Balloon commissurectomy also may be considered for severely symptomatic patient, NIHA class 3 or 4, with severe mitral stenosis, mitral valve area less than 1.5 centimeter, stage D, who have suboptimal valve anatomy and are not candidates for surgery or at high risk for surgery. This will be class 2B. Concomitant mitral valve surgery might be considered for patients with moderate mitral stenosis, mitral valve area 1.6 to 2, undergoing other cardiac surgery. This would be class 2B. Mitral valve surgery and excision of the left atrial appendage may be considered for patients with severe MS, mitral valve area less than 1.5 and stage C and C, who had a recurrent embolic event while receiving adequate anticoagulation. This is class 2B. Now I start about talking about the mitral regurg. We have primary mitral regurg and secondary mitral regurg, and each of them has stages. For the primary mitral regurg, we have 4 stages, A, B, C, D. Stage A, it's the patient who's at risk of mitral regurg. Valve anatomy will be mild mitral valve prolapse with normal coarctation. There would be mild valve thickening and leaflet restriction. The valve hemodynamics, there will be no MR jet or small central jet area less than 20% to the LA on the Doppler. There will be a small vena contracta less than 0.3 centimeter. There would be no symptoms. And progressive mitral regurg, class B, stage B, the valve anatomy will be severe mitral valve prolapse with normal coarctation. There would be rheumatic valve changes with leaflet restriction and loss of central coarctation or prior infective endocarditis. There would be a central jet mitral regurg 20 to 40% in the left atrium or late systolic eccentric jet MR. The vena contracta will be less than 0.7 centimeter. Regurgitant volume will be less than 60 cc. Regurgitant fraction will be less than 50%. And for the effective regurgent orifices will be less than 0.4. On angiographic, we can find angiographic grade 1 to 2. There would be no symptoms, but there is some hemodynamic consequences, which is mild LA enlargement. There would be no LV enlargement with normal pulmonary pressure. Stage C, which is asymptomatic severe mitral regurg, there would be severe mitral valve prolapse with loss of coarctation or flail leaflet. There would be rheumatic valve changes with leaflet restriction and loss of central coarctation. Or patient had prior infective endocarditis or thickening of leaflet with radiation heart disease. The valve hemodynamics, there would be central jet MR more than 40% to the left atrium or hollow systolic eccentric jet mitral regurg. Vena contracta will be more than 0.7. Regurgent volume will be 60, more than 60. Regurgitant fraction will be more than 50%. And for the effective regurgitant orifices will be more than 0.4. And on angiographic grade will be 3 to 4 positive. There would be no symptoms, but there's some hemodynamics consequences, moderate or severe left atrium enlargement, left ventricle enlargement, there will be pulmonary hypertension, may be present at rest or with exercise. In stage C, we can classify to C1 and C2. C1 is where is the ejection fraction, left ventricle ejection fraction more than 60, or the left ventricle systolic diameter will be less than 40. In C2 is ejection fraction less than 60, and the left ventricle systolic diameter will be more than 40. In systolic diameter more than 40. For stage D, patient with symptomatic severe mitral regurg, it's almost same stage C, with symptoms of decreased exercise tolerance and exertional dyspnea. Stages for secondary mitral regurg. Grade A, patient who's at risk of mitral regurg. Patient will have normal valve leaflet, cords, and annulus in a patient with coronary disease or cardiomyopathy. The valve hemodynamics, there is no MR jet or small central jet area less than 20% on LA on the Doppler. Small vena contracta less than 0.30. There would be symptoms due to coronary ischemia or heart failure may be present that respond to revascularization and appropriate medical therapy. Associated cardiac finding, we can see normal or mildly dilated LV size with fixed infarction or inducible ischemia, regional wall motion abnormalities. There would be primary myocardial disease with LV dilatation and systolic dysfunction. Grade B, by definition, it's progressive mitral regurg. Valve anatomy will be regional wall motion abnormalities with mild tethering of mitral leaflet. There would be annular dilatation with mild loss of central cohabitation of the mitral leaflet. Valve hemodynamic area, the effective regurgitant orifices will be less than 0.4. Regurgitant volume will be less than 60 ml. Regurgitant fraction will be less than 50%. Patient will have symptoms due to coronary ischemia or heart failure that respond to revascularization and appropriate medical therapy. Associated cardiac finding, regional wall motion abnormalities with reduced LV systolic function, LV dilatation, and systolic dysfunction due to primary myocardial disease. Grade C, which is asymptomatic severe mitral regurg. Patient will have regional wall motion abnormalities and or LV dilatation with severe tethering of mitral leaflet. Annular dilatation with severe loss of central cohabitation of the mitral leaflet. Valve hemodynamics, the estimated effective regurgitant orifices will be more than 0.40, regurgitant volume more than 60, regurgitant fraction more than 50%. Patient will have symptoms due to coronary ischemia or heart failure that may be respond to revascularization and appropriate medical therapy. Associated cardiac finding, regional wall motion abnormalities with reduced LV systolic function, LV dilatation, and systolic dysfunction due to primary myocardial disease. Grade D, it is the symptomatic severe mitral regurg. There is regional wall motion abnormalities and or LV dilatation with severe tethering of the mitral leaflet, annular dilatation with severe loss of central cohabitation of the mitral leaflet. The effective regurgitant orifices will be more than 0.4, regurgitant volume more than 60 ml, regurgitant fraction more than 50. Symptoms, heart failure symptoms due to mitral regurg persistent even after revascularization and optimization of medical therapy. Decreased exercise tolerance, exertional dyspnea. For associated cardiac finding, regional wall motion abnormalities with reduced LV systolic function, LV dilatation, and systolic dysfunction, primary myocardial disease. The recommendation for the diagnosis and follow-up. TE is indicated for baseline evaluation of the left ventricle size and function, right ventricle function, left atrial size, pulmonary arterial pressure, and mechanism and severity of the primary MR in stage A to D. In any patient suspected of having chronic primary mitral regurg. This is a class 1 indication. MRI is indicated, cardiac MRI is indicated in patient with chronic primary mitral regurg to assess LV and RV volumes, function, or mitral regurg severity, and when these issues are not satisfactorily addressed by the transthoracic echo. This is class 1. Intraoperative transesophageal echo is indicated to establish the anatomic basis for chronic primary mitral regurg, stages C and D, and to guide the repair. This is class 1 indication. TE is indicated for evaluation of patient with chronic primary mitral regurg stages, stages B to D, in whom non-invasive images provided non-diagnostic information about severity of mitral regurg, mechanism of the mitral regurg, and or status of the left ventricle function. This is class 1 indication. Exercise hemodynamics with either Doppler echo or cardiac catheterization is reasonable in symptomatic patient with chronic primary mitral regurg, where there is a discrepancy between symptoms and the severity of mitral regurg at rest, which is stages B and C. This is a class 2A. Exercise treadmill testing can be useful in patient with chronic primary mitral regurg to establish symptom status and exercise tolerance, stage B and C. This is class 2A. For the medical therapy for the chronic primary mitral regurg, the recommendation is for systolic medical therapy for systolic dysfunction is reasonable in symptomatic patient with chronic primary mitral regurg, stage D, and ejection fraction less than 60%, in whom surgery is not contemplated. This is a class 2A. Vasodilator therapy is not indicated for normotensive asymptomatic patient with chronic primary mitral regurg and normal systolic LV function. It's class 3 and there is no benefit from it. For the intervention for the chronic primary mitral regurg, mitral valve surgery is recommended for symptomatic patient with chronic severe mitral regurg, which is stage D, and ejection fraction more than 30%. This is class 1. Mitral valve surgery is recommended for asymptomatic patient with chronic severe primary mitral regurg and LV dysfunction, ejection fraction from 30 to 60, or end systolic diameter for the left ventricle is more than 40, and patient on stage C2. Mitral valve repair is recommended. It's a class 1, and for mitral valve repair is recommended in preference to mitral valve replacement when surgical treatment is indicated for patient with chronic severe primary mitral regurg limited to the posterior leaflet. This is a class 1. Mitral valve repair is recommended in preference to mitral valve replacement when surgical treatment is indicated for patients with chronic severe primary mitral regurg involving the anterior leaflet or both leaflet, when a successful and durable repair can be accomplished. This is a class 1. Concomitant mitral valve repair or replacement is indicated in patient with chronic severe primary mitral regurg undergoing other cardiac surgery. This is class 1. Mitral valve repair is reasonable in asymptomatic patients with chronic severe primary mitral regurg, stage C1, with preserved LV function, ejection fraction more than 60%, and LV and systolic diameter less than 40, in whom the likelihood of a successful and durable repair without residual MR is more than 95%, with an expected mortality less than 1% when performed at Heart Valve Center of Excellence. This would be class 2A. Mitral valve surgery is reasonable for asymptomatic patient with chronic severe primary mitral regurg, stage C1, and preserved LV function, ejection fraction more than 60, or end systolic diameter less than 40, with a progressive increase in LV size or decrease in ejection fraction on serial imaging studies. This is a class 2A. MV repair is reasonable for asymptomatic patient with chronic severe non-rheumatic primary mitral regurg, stage C1, and preserved LV function, in whom there is a high likelihood of a successful and durable repair with a patient with new onset of AF or resting pulmonary hypertension, the systolic pulmonary systolic arterial pressure reaching more than 50. This is a class 2A. Concomitant mitral valve repair is reasonable in patients with chronic moderate primary mitral regurg, stage B, undergoing other cardiac surgery. Mitral valve surgery may be considered in symptomatic patient with chronic severe primary mitral regurg and ejection fraction less than 30, stage D. This is class 2B. Transcatheter mitral valve repair may be considered for severely symptomatic patient, NIHA class 3 or 4, with chronic severe primary mitral regurg, stage D, who have favorable anatomy for the repair procedure and a reasonable life expectancy, but who have a prohibitive surgical risk because of severe comorbidities and remain severely symptomatic despite optimal guideline-directed medical therapy for his heart failure. This is a class 2B. Mitral valve replacement should not be performed for the treatment of isolated severe primary mitral regurg limited to less than 1/2 of the posterior leaflet unless mitral valve repair has been attempted and was unsuccessful. It's a class 3 and it's harm. For the chronic secondary mitral regurg diagnosis and follow-up, transthoracic...
Abir.
No.
Thank you so much. Let's slow down a little bit. So go back to the primary MR guidelines. So as you guys see here, as you see, the mastery of mitral valve intervention and mitral regurgitation is a mitral valve repair. And this is where the people talk about, right? So if the patient have a posterior mitral valve pathology, there's no reason for this patient to go for a mitral valve replacement, as you can see here. Unless if it's prohibitive to do a mitral valve repair, because like if there is a bileaflet prolapse and you don't have an experience, or if there is infective endocarditis in the mitral valve. Sometimes even infective endocarditis in the mitral valve involving the posterior mitral, if it's focal, you still can't repair the valve. So this is one of the most important things that you need to know about mitral valve repair. Even in asymptomatic patients, if you can achieve more than 95% of the time a repair, this patient to have a class 2A to go for a mitral valve repair. This is one thing. The other thing, it's in asymptomatic patients, if the patient develop a new onset of atrial fibrillation, even if he has no symptoms of mitral valve, like there's no shortness of breath, there's no decreased exercise intolerance, this is one of the indications that the patient should go for surgery or a pulmonary hypertension. Sometimes what cardiologists do, they do an exercise echo just to see how is the pulmonary hypertension do with mitral regurgitation. And even if the pulmonary hypertension goes beyond 50 with exercise, this is another indication that this patient should go for early repair. As you remember, when we talk about mitral valve repair, in the old era, people think we should do a watchful follow-up. But the new trend of mitral valve repair, if you're capable to do an early repair, this patient should go for a repair as early as possible to prevent the damage. Can you go to the next slide?
Yes, sure.
Now, the most important thing also, you have to look for the ejection fraction, okay? So the main player is the ejection fraction and the left ventricular and the systolic dimension. This is very important. When you look at any case of mitral regurgitation, you discuss the cases with echocardiographer, or when you look at your echo yourself, this is the two important parameters that you need to look for. And why we say the ejection fraction? Because in the mitral regurgitation, if the ejection fraction is less than 60%, that means this heart is not normal. Because as you know, that most of the volume will go back to the left atrium, so you will have over-exaggerated ejection fraction. So this is a very important that you need to keep an eye on when you see any patient with a severe primary mitral regurgitation. You look into the left ventricular ejection fraction and you look at the volume of the left ventricle. Because if the ejection fraction starts to drop less than 60, or volume left ventricle and systolic dimension more than 40, that means this patient is actually start to his ventricles start to take a hit, and this is where you need to be very careful. In terms of, go to the next slide, please.
Sure.
Also, you have to keep in mind the stages of heart failure, okay? Or the stages of not of heart failure, but the stages of the valve progression. This is also a very important player, and Abir presented very in detailed how we look into heart failure. I mean, stages of valve progression, from symptoms to echo finding. Okay, and the things that you need to keep in mind when patient presented with moderate MR, non-ischemic. This is, we talk about primary. You have to be careful about because MR is two different entities: the primary MR and the secondary MR. If the patient presented with primary moderate MR, and you have to operate on him for any other reasons, like he's going for cabbage or aortic valve, then you have to address the mitral valve. But when you talk about secondary MR, we're going to talk about this in the next. The level of evidence and the level of the recommendation, it's actually it's different. The last slide for the primary MR. Now this is a dilemma, because if the patient is symptomatic but his ejection fraction less than 30, the level of evidence goes from 1 to less than to 2B. This is very important, because you don't know, because that means this ventricle it's very severe, severely hit, and you're not really sure if you operate on this patient he will get better in future, because the remodeling of this ventricle will be very difficult. And that's why sometimes in those patients we consider send them for a different modality, either like minimally invasive mitral valve replacement with off-pump beating heart, which we do with a lot of new modalities of mitral valve replacement, or you send them for a mitral clip. This is sometimes reasonable in this group of patients. And finally, if the patient have primary posterior leaflet problem, if you're not sure that you'll be able to repair this valve, you should really, if the patient he can wait, you should refer him to another surgeon who could actually perform a good mitral valve repair on him. So as you see here, the mitral valve replacement should not be performed for isolated primary MR limited to the less than 1/2 of the posterior leaflet, unless if you go to the OR, you try to repair, you failed, and then you replace the valve. Okay? This is very important. This is the mastery of mitral valve intervention in primary mitral regurgitation. Thank you.
Thank you, Dr. Shnan. Okay. We will go for the chronic secondary mitral regurgitation for the diagnosis and follow-up recommendation. Transthoracic echo is useful to establish the etiology of chronic secondary mitral regurg, stage B to D, and the extent and location of wall motion abnormalities, and to assess global LV function, severity of mitral regurg, and magnitude of pulmonary hypertension. It's class 1. Non-invasive imaging like stress nuclear emission tomography, CMR, or stress echocardiographic, cardiac CT angio, or cardiac catheterization, including coronary arteriography, is useful to establish etiology of chronic secondary mitral regurg, stages B to D, and or to assess myocardial viability, which in turn may influence management of functional mitral regurg. This is a class 1. For the medical therapy recommendation, a patient with secondary mitral regurg, stages B to D, and heart failure with reduced left ventricle ejection fraction should receive standard guideline medical therapy for heart failure, including ACE inhibitors, ARBs, beta blockers, and or aldosterone angiotensin as indicated. This is a class 1A. For the intervention for the chronic severe mitral regurg, secondary mitral regurg, mitral valve surgery is reasonable for patients with chronic severe secondary mitral regurg, stages C and D, who are undergoing CABG or AVR. This is a class 2A. It is reasonable to choose chordal sparing mitral valve replacement over downsized annuloplasty repair if operation is considered for severely symptomatic patient, NIHA class 3 to 4, with chronic severe ischemic mitral regurg, stage D, and persistent symptomatic despite the medical therapy for heart failure. This is a class 2A. Mitral valve surgery may be considered for severely symptomatic patient, NIHA class 3 or 4, with chronic severe secondary mitral regurg, stage D, who have persistent symptoms despite the optimal medical therapy for heart failure. This is a class 2B. In patient with chronic moderate ischemic mitral regurg, stage B, undergoing CABG, the usefulness of mitral valve repair is uncertain. This is a class 2B also. That's it.
Can you go back, please, to the slide?
Yes, sure.
Okay. So, as you see here, that a patient with chronic secondary mitral regurgitation, first of all, you need to consider a medical therapy for these patients, okay? Before you try, this is class 1, before you even try doing anything. Now, if you go to the surgical management, go to the next slide.
Sure.
As you can see here, and this is very important, there is no class 1 indication to do anything for secondary MR, okay? If the patient have severe secondary MR and you're gonna operate on him, you have to, it's reasonable. That means it's class 2A to do anything for him. Now, if I ask you a question, Abir, where did this level of evidence come? You know, like why people said reasonable to do mitral valve repair? Do you know any studies in the literature that influence these guidelines?
For the level of evidence?
Not only the level of evidence, the mitral valve replacement.
Yes, what's the question again? I'm sorry.
Do you know the study that influenced these guidelines?
No.
Because all guidelines has an influence, right? Yes, the people in the they go back to, there is a paper which published in 2015 on New England Journal of Medicine, looking at the mitral valve repair versus mitral valve replacement in patients with heart failure. They followed the patient for 2 years, and they found that the patient with mitral valve replacement, they have less MR recurrence, and they have a better heart failure symptoms and less hospital admission. So for that reason, people say it's reasonable to do a mitral valve replacement in this group of patients. Okay.
Okay.
Now, as you see here, with chronic MR, there is also another study for the same group subsequently came to look at the moderate MR, and they did medical therapy versus mitral valve replacement, and it did not show any benefit of mitral valve repair. That's why they said it's uncertain. We don't know, and they need a subsequent or further operation. That's why I said when a patient presents with moderate MR and he's going for a CABG or going for aortic surgery, and this is secondary MR, you have to be careful about secondary versus primary. Then there is uncertain if you need to do anything. Just, in my opinion, you just do your primary surgery and treat him medically. You should get better. But if patient coming with severe MR, then here it's become you have to do something for this patient. Now, sometimes the patient have no, like let's say he has a coronary artery disease, but the patient was stented. He was sent home and he came back with a mitral regurgitation. It's still secondary. If this patient is treated treated with guideline-directed medical therapy, but he still has a heart failure symptom despite all the revascularization, then it's class 2B. That means you might do the operation, but it's sometimes it's difficult when you deal with this kind of pathology. Okay.
Yes.
You have to be very thoughtful about a mitral secondary MR when you do a repair, when you do a replacement. Well, we know that the recommendation said mitral valve replacement, but when you meet with people and like in meetings and on and you talk about mitral valve replacement repair in ischemic MR with MR expert people, there's still people think that if you do a good repair, the ventricle should recover or the patient should do better with mitral valve repair than replacement. And this is actually was very evident on the trial, because on the trial when they did the mitral valve repair versus replacements, the people who have a good repair, because the mitral valve recurrence in the repair group was about 30%. The 70% of people who actually have a good repair, they have actually a better echocardiographer finding for the left ventricle than the mitral valve replacement. Because when you read the paper, you have to be very critical and you have to dig in the data to understand the problem. But when the people have a recurrent MR, then these people actually do worse in terms of recurrent hospital admission and recurrent heart failure symptoms. Okay.
Yes.
Anybody have any questions?
Yes.
No. Yes.
If you look at, thank you for your presentation. If you look for hemodynamics of secondary MR, the regurgitant volume more than 60. Can you go back? Yeah, please. There is some discrepancies between this guidelines and the textbook in the Lawrence 2018. If you look for the where the hemodynamics, no, go back. Yeah, and severe secondary MR. No, this is primary. I will send the picture in the group. Actually, in the textbook, the Lawrence is half numbers. For example, regurgitant volume more than 30.
Okay.
Yeah,
this is a very important point. If you look at the old guidelines,
yeah,
it was the half, right? ERO of 0.2, regurgitant volume of 30.
But actually, it's updated in 2018 in Lawrence.
Yes, I know, but 2018 book.
Yeah.
Yes, it's still when they wrote this book or they print this book, they didn't have the latest guideline, which is 2017. Okay. So my recommendation to you, when you talk about echo findings or recommendation, you don't refer to textbook. Okay. Textbook, it's good to teach you about surgical techniques, about the pathophysiology, about the natural history, about the fate. But when you study for your exam, and this is my advice to you, you need to be aware of all updated guidelines. Okay.
Yeah.
Because this is where the exam will come from. Like when we did our Royal College exam, we studied I studied the studies, the guidelines, the questions more than I did the textbook. I read the textbook. Textbook is very important. But now the new era of the people will not ask you how to do the surgery, because during your training, what you're doing is a surgery.
Yeah.
But the most important thing is decision making. How the decision making come? From experience and from knowing your guidelines. Okay. Because if I'm going to give you a case in the exam, present you a case, because sometimes the initial discussion of this case, are you going to take the patient for surgery or not? How are you going to know if you're going to take this patient for surgery or not? Depends on your awareness of the guidelines, right?
Yes.
This is one thing. Second thing, it's the most important thing. When you read the guidelines, people will go make a mistake. They go just for the tables. They look at class 1, class 2. No. You have to read the body of the guidelines, because in the body of the guidelines, sometimes you find, because when the people write the guidelines, they will go and read all relevant studies that related to the same subject or topic in terms of echo investigation. Let me give you an example. If you read about aortic valve, let's say, because there is a low gradient, low flow, or paradoxical aortic valve, right? Stenosis.
Yes.
I try to read this topic from textbooks. I never have a good answers about how you diagnose and how you approach. Then go to the guidelines 2017. You will find the clear pathways of how you diagnose and what are the steps and how you tackle this problem. Okay.
Yeah.
So my advice to you when you read any topic, like you're gonna study aortic valve, okay? You read the whole textbook. You have a very good summary, but do not waste your time reading the indication of surgery from the textbook, because this is old.
Yeah.
You go to the guidelines. You summarize the guidelines, and you have to give it. Sometimes you have to read in the body of the guidelines, because also you will be surprised. You'll find a lot of information that is relevant, and there is actually a very hot topics for questions in the exams. Okay. So the good thing about AHA guidelines, it gives you all indications, like how you investigate, what's the medical therapy, what is the percutaneous therapy, and what is the surgical therapy. Okay, it's give you a full spectrum of the disease. Okay, discuss in details. And nowadays, us as a surgeon, we have to be aware of all the possible therapy for the patients. Okay, means when is the patient going to be, like mitral valve stenosis, when is the patient going to be suitable for percutaneous balloon? What are the indications? What is the guidelines? What's Wilkins scores? How you do Wilkins scores? You need to be aware of all this. Okay. This is one thing. Like mitral valve, you have to be careful. You have to be careful how to separate primary MR from the secondary MR. What are the findings that you look for? Okay. There's one thing more, like in secondary MR. What are the favorite, or what are the indicator that this patient will be suitable for repair? You know, the tenting areas, the mitral annulus angle, the ejection fraction, the left ventricular end diastolic dimensions, all these important things. Okay. Because people, when they look at end systolic dimension, that means this is early dilatation. Okay. But if you look for the very severe remodeling or very severe dilatation, we move from end systolic to end diastolic dimensions. Okay. So that's why when we try to put the topics for the teaching, we actually aim to be exam oriented. Okay. That's why it's very good to talk about mitral valve repair techniques, exposure. We talk about this in details, right? I did this with your teaching. Haytham did a great 2 talks. But the most important thing, you have to go back and you have to understand the guidelines, okay? Very carefully, because this is how you're gonna practice. The other important thing, sometimes there is discrepancies between guidelines. Like if you look at the American and European, this is another important exam questions, okay? Because sometimes we have been asked, what is the difference in the American and European guidelines in terms of tricuspid valve intervention? Okay. So I think you should build your practice on American guidelines, because this is most of, in my opinion, I mean, but you should be aware of other guidelines. Okay, like European, Canadian. Sometimes you find very useful information from both. Okay. And as I said, when you study for your exam, you really need to read the whole body of the guidelines, because sometimes it can give you very useful information.
Thank you so much, Dr. Muhammad. Thank you.
Yes. Assalamu alaikum.
Okay. Alaikum salam.
Yes, excellent presentation, Abir. You know, but just want to emphasize what Muhammad was telling you, when you do a guideline presentation, you should quote some important studies which have changed the from old guideline to new things have come up. They are always in the guidelines. You should present that abstract or of that study which has changed from the old to the new one. As Muhammad was emphasizing, that is very important to know where from this change has come. Another thing was very interesting, as Muhammad was telling, that when you have this stage 3 or 4 mitral valve and secondary, where there is a class 2B, but it is a little bit up now if you do a caudal preservation, and it becomes a class 2A. I think we have done cases. I think with Muhammad, we can do some more cases, and this will be very interesting whether they are in a search, in the research point of view, the caudal preservation in such patients. We see not a huge number, but a reasonable number where we do a caudal preservation. They present in class 4, they present with stage D in heart failure, pulmonary edema, and we do cabbage plus caudal preservation. I think we'll look these cases, and maybe it is a good topic for the research point of view. Thank you.
Thank you, Abir. If I can just add, emphasize more on Dr. Shaidan points, the trial he was asking for, it's named CTSN trial. And there is for severe secondary MR and also for moderate. Then you have Rami trial, you have, I think, Fattoush trial. Maybe not Fattoush, maybe I'm pronouncing wrong. And to go from replacement to repair, you have, for example, patient will benefit from replacement more. You have to keep in mind if their symptom, he mentioned it, Dr. Muhammad, if the primary symptoms like angina, so that's mean he will, the primary problem with him is revascularization. But if he present with the heart failure symptoms, that related to the MR. So MR need to be addressed. This is from history point of view. Then also patient with mitral, he will benefit more from replacement if you have poor target when you review your echo and BDA or CERC, or you have basal dyskinesia or aneurysmal or scarred when you review the echo, or you have ejection fraction less than 35. You mentioned tenting area more than, if it is more than 3, and also if you have a large ventricle, left ventricle insystolic, volume index more than 70, or insystolic dimension 55 or more, and diastolic dimension more than 65. Just the CTSN trials, I believe I wrote a summary about it. I presented in my last presentation. You can review that. And you have CTS for moderate, Fattoush, and Rami trial as well. Thank you.
Any other comment or questions?
Thank you.
Thank you. Haytham.
Yeah, hello.
Are we doing arrhythmia surgery this week with your group, the whole group, or no?
Yeah, I can announce it, and if you like, you can start with the first lecture, yani from 1 p.m. Thursday. Or if you want another time.
Okay. Question to you: is it you want us to talk about the atrial fibrillation surgery, or you want us to talk about 101 EP and then and then AFib surgery, or both?
Well, both is better. So it's like mini conference, small mini conference.
Then you have to give me the whole afternoon session because it's very big topic, huh?
No problem. We will do that. We will
and I might invite some of the EP doctors with the AFib talk, just to so they can join us with the meeting. Like they can because I want them to know what we're talking about, and also we'll take their opinion at some point. Okay.
Okay. خلاص. We'll announce it in the group today, and we'll give you the full session.
Okay, we'll do the first hour. It's 101 EP for cardiac surgeon resident. What do you need to know about EP? Pacemakers, CRT, ICDs. And then the next talk will be very expert talk about atrial fibrillation surgery.
So the first talk, we'll name it 101 AB for a cardiac surgeon. Okay.
Yes.
And second talk, surgical management of atrial fibrillation.
Yeah, but make sure. Okay, is Farid around? Like, is he going to be available?
Yes. Usually he's available.
I want him to be around for the second talk. Very important, for him to understand what's going on.
Okay, I will inform him inshallah.
طيب ماشي. Let me know.
خلاص.
بعدين. Okay.
Okay.
How you feel today? You're good?
Today, alhamdulillah, inshallah better. Less headache. Alhamdulillah, inshallah khair.
يلا